So just going back to the adverse effect question, I've certainly found that PARP inhibition seems overall to be well tolerated in the adjuvant setting. You mentioned myelosuppression as something we have to watch out for. Certainly some nausea and fatigue and kind of the usual AEs that unfortunately pop out with most of our therapy sort of popped out in Olympia. But anything else that you would mention for clinicians to keep in mind as they're counseling their patients with regard to the decision to use a PARP inhibitor?
I think you covered the big topics. So when you start the therapy, there's frequently a period of kind of low-grade nausea, and so we give people preventive antiemetics, low-grade antiemetics, Compazine or something like that, so that they can bridge themselves. That usually tachyphylaxis after a few weeks, and then after that they're okay. The blood counts, the biggest issue actually is anemia. And almost everybody who goes on a PARP inhibitor will develop macrocytosis. So you'll see that. And the problem with the anemia is that it can be sudden. In other words, they can be plugging along at a hemoglobin of 10, 9.8, something like that. And then the bottom can suddenly drop out and you can be in a place where you need to give transfusions. So unfortunately, one does need to both continue to monitor counts during the course of therapy. I usually monitor them monthly, and then have patients be aware that if they suddenly start feeling short of breath or have trouble with exercise tolerance, that this could be one of the possible causes and they need to get evaluated for it.
Yeah, absolutely. I have not seen any compounding toxicity you discussed earlier with regard to combining immunotherapy with PARP inhibition, and certainly not with combination of endocrine therapy. Is this consistent with what you're seeing?
I counted once how many trials there were of combination PARP and Pembro, and it was large. It was like 40 trials, and there's no safety signals. And same thing with endocrine therapy. There's no real reason to expect any overlap apart from CDK4/6 inhibition. So I have no concerns about combining them.